This is another case. This is a 62-year-old man with hypertension. He's presenting with exertional dyspnea and dizziness over the last 6 months that made him really alter his lifestyle. On echo, he has normal EF, moderate LVH, severe left atrial enlargement, mild MR, mild AI. Coronary CTA shows severe LAD calcification. So he was referred to us for coronary angiogram. And on coronary angiogram, we found serial 40% mid-LAD stenosis, not significant by IFR. We did the standard left heart catheterization and pullback, and those are the waveforms. They are not high quality, but interestingly, despite not being high quality, they are suggestive of a diagnosis. So I want you to analyze the LV waveform and the aortic waveform. First, let's analyze the aortic waveform. What is striking about that aortic waveform is that it has a wide pulse pressure. The pressure is 150 over 50. Wide pulse pressure. We call it wide pulse pressure when that pulse pressure is more than half the systolic blood pressure. So that's one anomaly. Why this relatively young person have such a wide pulse pressure? Second finding, look at the LV. In diastole, what's the LV-EDP? The LV-EDP is this bump here after the LV-A wave. So it's about 30 millimeter of mercury. So it's a high LV-EDP. You can think, okay, this patient has diastolic dysfunction and he has severe left atrial enlargement, LVH. Maybe that's why he's having all those problems. But that high LV-EDP with a low diastolic blood pressure should always make you think of severe aortic insufficiency, specifically severe decompensated aortic insufficiency. When that aortic diastolic pressure almost meets the LV and diastolic pressure, this is very suggestive of aortic insufficiency. When the difference between those two, aortic diastolic pressure and LVDP, is less than 30 millimeter of mercury or less than 25% of the systolic blood pressure, the so-called aortic regurgitation index, when you have that narrowing of that difference, then this is very suggestive of AI. In AI, you get that massive regurgitant flow that makes the aortic pressure drop and it makes the LV pressure rise. In chronic AI, you get adjustments of the LV compliance, and the LVDP and aortic diastolic pressure may be well separated, so you may not have that joining of diastolic pressure, narrowing of diastolic difference in a chronic compensated AI, but you definitely have it in decompensated symptomatic AI, as in this patient, or in severe acute AI, where they actually touch each other. So this is what this simple recording, just paying attention to simple things, made us think in this patient, even though his echo suggested mild AI. Now that's the problem with echo. Echo color correlates with velocity more than volume. So AI volume may be high, yet it may be eccentric, so that AI jet hits the wall, its velocity slows down, and the color may abate quickly. So echo underestimated AI in this patient. And how can I prove AI? Well, we can use a somewhat quantitative method. In the cath lab, when you see something like this, you can keep going and do an aortogram, which is semi-quantitative, as opposed to echo, which uses velocity. Here we're using volume. We're not quantifying the volume. That's why it's semi-quantitative. It's based on eyeball and contrast density. And I want you to know the AI angiographic classification. This is very severe AI here. So we're injecting dye in the aorta. This is in an LAO view. And you can see flow back in the LV. And you can see that LV filling eventually more dense than the aorta here. This LV is more dense than the aorta. And it's filling as densely as the aorta within 1 beat already. Within 1 beat, already it's filling as much as the aorta, and within subsequent beat, it becomes more dense than the aorta. This is what you call 4+ aortic insufficiency. And I want you to know that Seller's angiographic severity of AI, you really need to know it. And it also the same applies for MR. So we classify angiographically AI and MR into 1+ to 4+. 1+, you have a small puff of regurgitant contrast go from the aorta to the LV, but you do not fully opacify the LV. You just see a puff there. 2+, the LV fills fully, but is less opacified than the aorta throughout the whole injection. It never fills as much as the aorta here at this level above the catheter. 3+ means the LV fills fully and is as opacified as the aorta eventually. 4+ means the LV fills as much, as densely as the aorta on the first beat and ends up being more dense and more opacified than the aorta. 3+ is already severe, 4+ is very severe. So LV more dense than the aorta is 4+, LV as dense as the aorta is a 3+. And in 4+, LV becomes already as dense as the aorta within one beat and becomes more dense in subsequent beats. Same applies for MR. We inject the dye in the LV and we see how the LA fills. 2+, the LA fills fully but is less opacified than the LV. 3+, the LA fills fully and is as opacified as the LV. 4+, LA fills as densely as the LV on the first beat and ends up being with a greater density than the LV. There is a catch in the MR assessment is that there may be overlap between 2+ and 3+. When the LA systolic volume is larger than the LV systolic volume, 2+ may be severe already, simply because it's hard to fill that LA and make it more opacified than the LV, simply because it's bigger than the LV in systole. So even if your regurgitant fraction is 50%, which is what defines MR, the LA may remain less dense than the LV because it's bigger than the LV in systole. And I want you to know how do you obtain those angiograms. I notice a lot of fellows these days don't know those numbers. Remember those rules: how much volume and what view. For MR, you need to do RAO view to set apart the descending aorta from the LA so you can see exactly what's the LA density as it's filling. So you do steep RAO view. You can also do LAO cranial view, which also, again, set apart the LA from the LV here and from the aorta. So you do either one of those, and you have to inject big volume. Remember those numbers. 12 milliliter per second for 4 seconds, about 48 to 52 milliliters. For AI, we do an LAO view typically, and we inject 20 milliliter per second for a total of 50 to 60 milliliters. So big volumes. To give you an idea, when you do standard LVgram, when we're not aiming to assess severe MR, we use only about 20 to 25 milliliters in total. So we use here about double to assess MR because we want to see good filling to get that semi-quantitative assessment. Another idea in this patient, his peripheral blood pressure was 180/40, while our invasive aortic pressure was 150/50. That's another hint to AI. So paying attention to small things beside that hemodynamic waveform, this is what we call dramatic peripheral systolic amplification of pressure, which also in context suggests AI. So in AI, you get a dramatic peripheral systolic amplification of pressure between the aorta and the brachial and radial artery. And this is the result of the big initial stroke volume wave of AI hitting the thicker and less compliant peripheral arteries, which causes that big spike in pressure in the peripheral arteries. This is what we call the Hill sign. And when the difference is over 40 millimeter of mercury in systole, especially over 60, it is suggestive of AI. And that's one reason why it's very hard to control the blood pressure in severe AI, especially the peripheral blood pressure in severe AI. We still use angiography to assess AI and MR. It's still a helpful tool in questionable cases, along with MRI and TEE. This is another case. This is an aortic pressure waveform. What diagnosis does it suggest? This is a classic pulsus paradoxus. See how with respiration you get a near full collapse of the aortic pressure. This is not just mild respiratory variation in pressure. This is a full collapse of the stroke volume. Look at this with respiration. Look at this. There is no PVC here. This collapse in waveform is not due to a rhythm issue. It's just respiratory variation, which diagnoses pulsus paradoxus. Look, the full collapse. And that's what pulsus paradoxus. It's a collapse of that pulse pressure, both in height and width, in overall area under the curve with respiration. And this correlates with what you have on physical exam. The pulse may feel irregular. It gets weak or abates at times and comes back. So it feels irregular, yet the rhythm is regular. And that's usually a hint to tamponade. And this is the same patient after pericardiocentesis. One, you have much larger pressure waveform and stroke volume in all cardiac cycles, and there is a whole lot less of respiratory variation. There is no pulsus paradoxus. And this is the pericardial pressure in this patient. Notice two things. The pericardial pressure is high, and the pericardial pressure normally in those patients is equal to the RA pressure. And it's actually high and compresses the RA pressure and makes the RA pressure rise and match that pericardial pressure. That's the definition of tamponade. It's a pericardial pressure that compresses at least one chamber, typically the right-sided chambers in diastole. What's characteristic of that pericardial pressure waveform and, in fact, the RA pressure waveform? Remember, whenever you have tamponade, you lose the Y descent. So you get AX, V, flattened Y. You see the V, then A. AX, you see pronounced X descent. V, flattened Y. AX, V, flattened Y into an A wave. So you get flat Y descent. And this is another illustration from another case. AXV, flattened Y. AXV, flattened Y. And after pericardiocentesis, two things happen. The pericardial pressure drops, and it should drop to normal. The normal being 0 with a drop to negative during inspiration, as is the case here. And the RA pressure drops to normal, and the RA pressure regains its Y descent. Frequently, the pericardial pressure may not drop back to 0 after pericardiocentesis. It may remain a little high in the single digits just because of the pericardial inflammation that causes a little bit of an increase on pericardial pressure that will resolve progressively over time. However, if the pericardial pressure or the RA pressure do not decline over 50% at least, then you're thinking of full-blown constrictive pericarditis. So you had what we call effusive constrictive pericarditis. Overwhelmingly, that would be what we call inflammatory constrictive pericarditis due to inflammation of the pericardium, not fibrosis of the pericardium, overwhelmingly in those patients with effusive constrictive pericarditis. And that constriction will also resolve with time, particularly with anti-inflammatory medications. But the two things I want you to know here, the pulsus paradoxus, that dramatic variation of aortic pressure, and the RA and pericardial waveform characteristics in patients with tamponade, flat Y. This is a 73-year-old female. She has a history of bioprosthetic MVR failure followed by placement of a sapient valve-in-valve transcutaneous MVR. She also had severe tricuspid regurgitation, and she received transcutaneous TVR with a sapient valve in 2018. So she has transcutaneous sapient valve in the mitral and tricuspid position. After that, she continued to have severe progressive PH, considered precapillary on prior right heart catheterizations over the years. She has been placed on multiple pulmonary vasodilators, but she continued to decline clinically. So she was referred again to us for right heart catheterization, and these are her numbers. Her PA pressure was 72/20 with a mean of 40, and her wedge pressure was 18. So she still had severe pulmonary hypertension with RV failure and a RA pressure of 16. And notice the wide PA pulse pressure. Whenever you see that, your automatic reflex is that the patient has high flow state, such as high output heart failure, maybe severe anemia, severe obesity, lung disease, liver disease. Another possibility with a wide pulse pressure is pulmonic regurgitation, much less common. And a third possibility is pulmonary obstruction, such as PE, or in congenital disease, peripheral pulmonic stenosis. In those cases, you have a reduced pulmonary compartment, so whatever stroke volume hits it is relatively large for it and creates that wide pulse pressure. So don't ignore wide pulse pressure. Try to find out why it's wide. Now, we did a simple thing that we do routinely and we should do routinely that unfortunately was not done in any of the prior right heart cath over the prior years. We just did the standard screen that I always do. I got SVC O2 sat and I got PA sat. And this is what I found. The SVC sat was 47%. The PA sat was 70%. There was a huge step up, and we kept repeating those measurements to confirm. And there was consistently 22 to 24% step up between the SVC and the PA saturation. Therefore, this patient has a huge left to right shunt that was missed on prior right heart cath because a simple SVC sat was not performed. So after looking at those numbers, we also did a full oximetry run, and the RA sat, mid RA was 50%, the RV was 74%. So the step up was mainly at the RV level, and therefore the shunt is either at the low RA level or at the RV level. So looking at this, I want you to do two things. Calculate to me the QP-QS ratio and calculate the PVR. So to calculate the QP-QS, use that quick equation. The arterial sat here is 93%. There is no right to left shunt for two reasons. Even though the arterial sat is a little low, there is no right to left shunt because it was going up very easily whenever we give her 1 liter of oxygen or we ask her to take a few deep breaths. That's one. Number two, the wedge pressure sat matches that. Despite the limitation of wedge pressure sat that I explained under my shunt hemodynamics talk, in this case, it further confirmed that there is no right to left shunt. So in that case, we assume that the pulmonary venous O2 sat is equal to the arterial sat of 93%. And you plug in the quick QP-QS calculation, which is arterial sat 93% minus the lowest, 47%, divided by 93% minus the highest, 70%, the PA sat. Now the second question is how to calculate the PVR. The PVR is mean PA pressure minus LA pressure divided by cardiac output. And here is the very important message I want you to learn. Whenever you have a shunt, we do not talk about cardiac output anymore. There is no such thing of cardiac output. Do not use the term cardiac output. We have two cardiac outputs. We have left-sided output and right-sided output, which are different. You have to calculate in each shunt case QP and QS, not just the QP-QS ratio. You have to calculate the absolute QP and the absolute QS. And PVR would be mean PA minus LA divided by QP on the pulmonic circulation. And this is how we calculate QP and QS using the Fick equations. And for QP, the sats we use are the pulmonic side sats, which is the pulmonary venous sat equal to arterial sat in most cases, and the PA O2 sat. For the QS, we use the arterial sat and the O2 sat in the SVC, the mixed venous O2 sat. And in most labs, we use the assumed FIC that assumes the O2 consumption and supply based on the body surface area. And this is what we did in this case. And this is the bottom line of our findings. So the patient had significant left to right shunt with significant 22 to 24% O2 step up between the SVC and the PA, confirmed with 4 rounds of oximetry runs. The wedge PA saturation and systemic O2 saturation are 93%. The QP-QS flow ratio is equal to 2. The systemic QS flow that we calculated using the FIC in absolute value is 2.6 liter per minute. It's very low with an index QS of 1.9. The pulmonic QP flow is 5.2 liter per minute. And as a result of this math, we were able to calculate PVR, which is that mean PA 40 minus 18 divided by QP of 4.2 Wood units. And the final diagnosis is severe pulmonary hypertension with a wide PA pulse pressure, 70/20 with a mean of 40, driven predominantly by the high pulmonary blood flow from the left to right shunting. There is also a mild postcapillary component and a mild precapillary pulmonary vascular component, PVR of 4.2 Wood units. Do not use thermodilution in those cases. Thermodilution in those cases is neither QP nor QS. You should throw it away. Another point I highlight here, when we were doing the case, before we did the oximetry, I was bothered by that very wide PA pulse pressure. Why does this patient has a wide PA pulse pressure? Whenever you have a very wide PA pulse pressure, it's usually indicative of a high flow state. High output heart failures, or it could be a shunt that causes wide pulse pressure. And since this patient did not have a high output, our next thought was shunt, which was indeed confirmed by oximetry. And this shunt may be iatrogenic, related to the valves, whether during placement or later on, shunt at the ventricular septum or the low interatrial septum.